If you carry APOE4, the next 15 seconds could redefine everything you thought you knew about your treatment options. Because for the first time in Alzheimer's research history, we have clinical trial data showing amazing results for APOE4 homozygotes. And here's the kicker: zero brain swelling, zero bleeding, zero deaths. This isn't another antibody treatment requiring monthly infusion and constant monitoring. This is something entirely different, an oral medication that fundamentally could prevent the formation of the most toxic proteins in our brain. Hello, I'm Dr. Kevin Tran, Doctor of Pharmacy and APOE4 carrier. I'm also the founder of the Phoenix community, where hundreds of APOE4 carriers are working together to beat the odds. I dive deep into the latest research and translate complex findings into clear, actionable insights we can all apply today. And today, from the Alzheimer's Association International Conference that just happened end of July 2025, and today we're diving into the breakthrough data from the Valiltramiprosate clinical trial, and it fundamentally changes how we think about treating Alzheimer's in APOE4 carriers. So this isn't about removing plaques after they form. It's about preventing the most toxic form of amyloid, oligomers, from ever developing. These oligomers are small soluble clusters of amyloid proteins that are 10 times more toxic than the plaques we see on our brain scans. Well, and the results, well, they're unlike anything we've seen before in 40 years of Alzheimer's research. Let me show you what this means for our future. So for years, the Alzheimer's field has been obsessed with plaques. Those are those little clumps of amyloid you see on brain scans. But what if I told you that the real killer has been hiding in plain sight, invisible to PET imaging? And remember, a PET scan costs like $5,000 to $8,000. So even those, they could not detect the oligomers. So Dr. Sam Gandhi from Mount Sinai presented data that completely flips our understanding. His team compared different forms of amyloid beta from tiny monomers, so monomers, mono means single, so single molecules, to dimers, di means two, so two molecules, oligomers, which are small clusters, and protofibril, which are larger type of chains, and finally the massive plaques we're all familiar with. And what they found was shocking.
The oligomer-rich fraction F, shown here with the 25% mole fraction of A-beta-42, is the most toxic. In fact, the more fibrillar the A-beta becomes, the less toxic it becomes.
Think about that for a little moment. The larger the amyloid structure gets, moving from oligomers to fibril to plaque, the less toxic they become. It's completely counterintuitive, right? The most dangerous form of amyloid is the one we can't even see on our standard brain scan. These oligomers are like molecular assassins. Small enough to move freely through the brain tissue, but toxic enough to kill neurons on contact. Yet, they are invisible to our current 5K PET scans. But here's where it gets even more compelling. Dr. Gandhi showed us patients with the Arctic mutation. So that's a genetic variation at position 22 of the amyloid beta protein, where glutamate is changed to glycine. And that causes Alzheimer's, but with a twist that proves oligomers alone can destroy the brain.
Both of these carriers have totally negative amyloid scans. And this carrier already has clinical Alzheimer's. So this patient's scan will never become positive. It's not that this is early, it's because they're accumulating primarily a form of A-beta that does not bind, that's non-fibrillar.
This is groundbreaking. These patients have full-blown Alzheimer's with completely clean amyloid PET scans. So those scans typically show a standardized uptake value ratio, or SUVR, of 1.5 or higher in Alzheimer's patients, but they remain at normal levels, which is below 1.1, in these Arctic mutation carriers. Their brains are being destroyed by invisible oligomers, not visible plaques. And for us as APOE4 carriers, this is crucial because we form oligomers faster and in higher concentration than the general population, because our genetic variant accelerates this toxic process by around 4 to 5 years compared to non-carriers. Yes, I know it kind of sucks. So Dr. Gandhi's team also discovered exactly how these oligomers destroy our neurons. And it happens at the most fundamental level of brain communication, at the synapses where neurons exchange chemical signals.
Tavio Roncio from Columbia discovered this presynaptic physiological defect that has to do with replenishing synaptic vesicles at the nerve terminal, that is, a repackaging transmitter into the vesicles. And that seems to be an important correlate of the toxicity of these oligomers.
The oligomers essentially jam the machinery that allows our neurons to communicate. Think of it like this. Neurons communicate by releasing packets of chemicals called neurotransmitters from tiny bubbles called vesicles. Oligomers prevent these vesicles from refilling, like trying to reload a gun that's been welded shut. The system simply stops working. Without this constant recycling of neurotransmitters, brain cells can't talk to each other, and cognitive function rapidly deteriorates. This happens long before any plaques forms, which explains why some people show cognitive decline years before their brain scans turn positive. Now that I've scared you about this invisible killer, let's talk about a solution. Because we understand that oligomers are the real enemy. But how do we stop them? This is where Valiltramiprosate, also known as ARZ-801, enters the picture with a completely novel approach that's fundamentally different from the FDA-approved antibody treatments like Leqembi or Aduhelm. Quick pause. If you're finding this research as revolutionary as I am, make sure you are subscribed and hit the notification bell so you don't miss our future videos. We're uncovering breakthroughs like this every week that could literally change the trajectory of your brain health. All right, so Dr. John Hay from Alzion explained the mechanism, and it's unlike anything currently approved for Alzheimer's. While antibody treatments work by binding to and removing amyloid after it forms, requiring monthly IV infusion that can cost 20 to 50K per year, Valiltramiprosate takes a preventive approach. And if you have been following our videos and the Phoenix community, we love anything that happens before developing symptoms, because this is where you can act the best and where you get the best results.
When you get to 1,000 to fold, you're interacting with any between 7 and 13 epitopes to change the conformation of the monomer. That disallows the aggregation.
So let me translate that. Instead of trying to remove toxic oligomers after they form, Valiltramiprosate surrounds individual amyloid molecules, the monomers, at a concentration 1,000 times higher than the amyloid itself. At this ratio, the drug molecules interacts with 7 to 13 binding sites, those epitopes, on each amyloid monomer, and that physically changes its shape so it cannot stick together anymore to form those oligomers. It's prevention at the molecular level, like putting protective caps on Lego blocks so they can't connect. Dr. Kenjiro Ono from Kanazawa University in Japan independently verified this mechanism using sophisticated techniques including high-speed atomic force microscopy that can capture molecular interactions in real time. I actually didn't know that existed, and discovered something even more remarkable. The drug has a dual mechanism of action.
ARIA-H inhibit beta-42 aggregation through dual mechanism prevention of both nucleus formation and fibril formation phase, in addition to promoting the formation of large globular non-toxic oligomers.
This is so fascinating. Not only does it prevent toxic oligomer formation at the nucleation stage, basically when monomers first start sticking together, but it also blocks the elongation phase, which is when those small clusters grow into larger toxic structures. So the thioflavin T assay Dr. Onu used, which is a standard test where fluorescence increases as amyloid aggregates, showed the drug extended the lag time before aggregation from 1 to 24 hours. Dr. Ono explains this off-pathway mechanism further.
We consider that LG801 may convert low molecular weight A beta into off-pathway, resulting in formation of large globular non-toxic oligomer and inhibition of further fibril formation.
It's like having a traffic controller that not only stops the cars from crashing, but redirects them to safe parking areas. I love these metaphors. The amyloid that would normally form toxic oligomers, so remember that's 2 to 12 molecules in a size and highly neurotoxic, is instead guided into large globular formation over 100 molecules and that are non-toxic. Because those our brain's cleanup crews, the microglia cells, can safely handle without triggering any inflammation. Now, for the clinical results that have everyone talking. Dr. Hay presented data from the APOLLO-E4 study, a phase 3 trial with 325 completers, all of them APOE4 homozygotes, specifically focused on those with MCI, and the numbers are unprecedented.
52% benefit on ADAS-cog and 102% benefit on CDR. ADAS-cog is maintaining above baseline for 52 weeks and still highly significant at week 78 with a p-value of 0.04.
Let me emphasize what this means. The ADAS-cog, that's the Alzheimer's Disease Assessment Scale, basically a cognitive test score from 0 to 70, where higher scores means worse cognition, stayed above baseline for an entire year. In practical terms, patients weren't just declining more slowly, they were actually improving. That's what above means. And it's a little bit early to say this generalization, but in 40 years of Alzheimer's research, it's extremely rare to see these type of results in APOE4 homozygotes. But cognition is only part of the story. What about daily function, the ability to maintain independence, manage finance, drive safely?
The CDR sum of boxes remained at baseline for the entire 78 weeks. The DAD, which is a purely functional endpoint, and here we had highly significant at week 78.
So the CDR sum of boxes is an 18-point scale that measures real-world functions across 6 areas like memory, judgment, and home activities. And that stayed flat at baseline for 78 weeks while placebo patients declined. Each point on this scale represents meaningful functional change. Staying at baseline means these patients maintain totally their independence and they could continue manage their own finances, driving, maintaining their households. The DAD, another functional assessment, confirmed this preservation. For us as APOE4 carriers who typically face rapid decline after first symptom onset, usually losing 2 to 3 points per year on these scales, this is almost revolutionary. But here's what really convinced me this is different from everything else: the brain imaging data. While antibody treatments often cause brain shrinkage, which we call pseudoatrophy, of about 10%, even as they remove plaques, which is a concerning side effect that's still not fully understood, Valiltramiprosate showed the opposite.
Hippocampal volume, 0.04, and cortical thickness, ventricular volume, and whole brain highly significant in all regions, indicating a very substantial effect on neurodegeneration or the progression of neuronal injury and atrophy.
Every single brain region measured showed protection from atrophy. The hippocampus, which is critical for forming new memories and typically losing 3 to 4% volume per year in MCI, was protected with a p-value of 0.04. Cortical thickness, measuring the gray matter where most brain processing occurs, was preserved. Ventricular volume, the fluid-filled spaces that expand as brain tissue is lost, showed less enlargement. The whole brain volume protection was highly significant, and this comprehensive neuroprotection directly correlated with cognitive improvement. So Dr. Hay then revealed something extraordinary about this brain protection that puts it in real-world context.
Greater the protection in hippocampal volume, process here, which is about -2 in the ADAS-cog, which would be considered highly clinically meaningful and significant. And that represents about a protection of 50 millimeters cubed, which translates into a protection of over 1 million neurons.
Over 1 million neurons saved. That's a lot. To put that in perspective, the human hippocampus contains about 40 million neurons total. Saving 1 million neurons represents 2.5% of this critical memory structure, enough to maintain the neural circuits needed for forming new memories and retrieving old ones. We're not looking at an abstract number, the 2.5%, right? We're talking about real brain tissue, real cognitive reserve that we are preserving, and the correlation was incredibly strong.
The highest group that had the most differential effect relative to placebo also had the highest baseline. As you go down, if you start treatment in those subjects that they had more atrophy at the beginning, the response is lower, highly correlative, 0.89.
A correlation of 0.89, where 1.0 would be the perfect correlation, is remarkably strong for clinical research. It means that the more brain volume you preserve, the better your cognitive outcomes, almost in lockstep. This provides us with a clear, measurable biomarker, which is baseline hippocampal volume, which can be assessed with a standard MRI that costs around $1 to $3K in the US to identify who will respond best to this treatment. Those with hippocampal volumes above 7,000 cubic millimeters showed the best response, while those below 6,000 showed limited benefit. And once again, that showed that you need to take prevention seriously. The earlier you act, the better the result, and that will be true for all sorts of drugs and also lifestyle interventions. And this is why in the Phoenix community, we are so focused on finding all the interventions we can to at least delay the progression of the disease, because the more time we gain, the more we can wait for these therapies that will come out of clinical trials and that will test. So it's not a matter of if we will solve Alzheimer's one day for sure, it's a matter of when. And we want to be ready to have our brain as healthy as possible when those therapies start appearing on the market. All right, back to the conference. This is where it gets even more interesting. Dr. Hugo Gertz presented quantitative system pharmacology, so that's QSP, modeling computer simulations that integrate all the biological processes of Alzheimer's that revealed something unexpected in some patients.
For the APOE4 homozygotes, the hippocampal volume actually at the end of treatment is somewhat higher than at the beginning of treatment. And this is a way to explain this type of super responders, which turned out to be characterized by younger age.
So some patients didn't just stop losing brain volume, they actually gained it back. These super responders were predominantly younger APOE4 homozygotes. And by the way, younger in this setting is an average age of 63. So everything is relative, right? Those super responders started treatment early with higher baseline MMSE. The MMSE, for those of you who don't know, is a mini mental state examination scored between 0 and 30, and a score above 27 indicates normal cognition. This suggests possible neurogenesis, which is the growth of new neurons or the recovery of existing brain tissue when we intervene at the right time before irreversible damage occurs. Now let's address the elephant in the room: safety. We, as APOE4 carrier, face the highest risk of ARIA, the amyloid-related imaging abnormalities, which is basically brain swelling and microbleeds, which are typically coming with antibody treatments. With Leqembi, APOE4 homozygotes have a 33% risk of brain swelling and 39% risk of microbleeds. This is very high. Some of us are even excluded from these treatments because the risk is deemed too high, especially if we're on blood thinners.
We did not see any increase in ARIA-E or ARIA-H. There was no symptomatic ARIA. We also have similar, no findings in the phase 2 study. There are no deaths. The SAEs were similar between active and placebo.
Zero ARIA. Let that sink in. It's an oral medication, a pill you take twice a day at 265 milligrams per dose with no brain swelling, no bleeding, no need for monthly infusions that take 1 to 2 hours in a clinic or in a hospital. No need for MRI monitoring every 3 to 6 months that costs like a few thousand per scan. The most common side effects was mild nausea in about 14% of patients, which typically resolve with continued use. And the safety profile is so clean that it opens treatment to all APOE4 carriers, including those who can't receive antibody treatment. I know navigating all these treatment options and understanding what's right for your specific situation can feel overwhelming. That's why I created the Phoenix community, where hundreds of APOE4 carriers share the experience, track biomarkers together, and support each other through this journey, because no one should have to figure this out alone. Dr. Gertz's computational modeling, calibrated with data from 7 different anti-amyloid antibody trials, including Clarity and Trailblazer, revealed why we, as APOE4 carriers, actually have an advantage with this treatment, which is a complete reversal of our usual disadvantage.
The impact of the ALZ801 actually is the greatest in the APOE4 homozygotes compared to the other groups. The earlier you get there, the more impact you have in terms of the reduction in the protofibrils and soluble protofibrils and oligomers.
So this is counterintuitive, but actually makes perfect sense. Because we form oligomers faster, our APOE4 variant reduces amyloid clearance by 40% and increases production by 15%. So because we form these oligomers faster, we also have more to gain from preventing them. It's like having a leaky pipe. The faster the leak, the more benefit you get from fixing it. The modeling showed exactly how this plays out over time.
The APOE4 homozygotes actually have a dramatic drop, about 4 to 5 years ahead of the non-APOE4 homozygotes. And this drop actually corresponds to the onset of the soluble oligomer formation.
Our CSF-A beta 42 drops 4 to 5 years earlier than non-carriers. So CSF-A beta 42, that's cerebrospinal fluid amyloid beta 42, and you can measure it through a spinal tap for about $500 to $800, but that's very painful, or estimated through a new blood test like p-tau217, and that one is around 94% accurate and only costs like $300 to $400 at Quest or LabCorp if you're in the US. Normal levels are above 600 picograms per milliliter, and they drop below 400 when oligomer formation accelerates. This earlier timeline means we have a clearly defined window for intervention, potentially identifiable through these increasingly accessible biomarker tests. Dr. Hay showed age-specific modeling data that drives this point home with real concentration targets.
If you treat earlier, you see a very significant increase in the protection or the inhibition of oligomer formation starting at 62 all the way to 75 years old.
So the sweet spot appears to be starting treatment in our early 60s, when brain concentrations of 20 to 40 micromolar can be achieved, well above the 10 micromolar threshold needed for oligomer inhibition. This is before significant oligomer accumulation, but after the process has begun. Dr. Gertz explained why timing is so critical using aggregation kinetics.
The slope of the aggregation here is very fast in the earlier stages and gradually tends to level off when most of the soluble oligomers are now going into an equilibrium state when they are attaching to the plaques.
Oligomer formation follows a sigmoidal curve. It starts slowly, which is called the lag phase, accelerates rapidly, which is called the exponential phase, and then plateaus, which is called the equilibrium phase. Once you hit the exponential phase, the cascade becomes much harder to stop because oligomers act as seeds for further aggregation. That's why early intervention, as always, is crucial for us. We need to act during the lag phase or early exponential phase, typically in our late 50s to early 60s for APOE4 homozygotes. This isn't just about individual patients. It's about a massive underserved population that's been largely excluded from current treatment options.
In the homozygous, worldwide it's about 16 million, and in the US the MCI population is about 1 million. Japan is a little bit less, about 0.9, and also Europe is over 2 million.
16 million APOE4 homozygotes detected worldwide. In the US alone, we have 1 million APOE4 homozygotes with MCI who could benefit immediately. While APOE4 testing now available for a few $100s at whole genome sequencing companies, or for medical grade testing through like Quest Diagnostics, for example, more people are discovering their status and seeking treatment options. We're talking about the treatment that could transform the trajectory for all of us, and the potential extends even further into prevention.
We believe that this has promise in the preventative space, the pre-symptomatic space. If you start earlier in the treatment, it indicates the potential for treatment at the earliest stages with benefit.
Prevention, not just treatment after symptoms appear, but actual prevention of cognitive decline in high-risk APOE4 carrier. This could mean starting treatment in our 50s or early 60s before any symptoms appear, where biomarkers like plasma p-tau217 or the amyloid beta 42-40 ratio, normal above 0.06 and concerning below 0.05, first show changes to prevent oligomers from ever accumulating to toxic levels. And of course, it's not only limited to homozygotes. The treatment could actually help millions more.
We plan to expand into heterozygous. We have data from the phase 2 that indicates that the profile that we see with the homozygous, we see that as well as in heterozygous. Mechanistically, they respond similarly.
This dramatically expands the triple population to include APOE3/4 carriers. That's people with only one copy of the risk gene. So that's about 25% of the population. Yes, 1 out of 4 people in the world have at least one E4 allele. So that potentially helps tens of millions of people worldwide who know they carry the gene. The phase 2 data showed similar benefits in heterozygotes when matched for disease stage, suggesting the mechanism works regardless of APOE4 gene dose. The key is matching treatment to the right stage of disease progression, which occurs later in heterozygotes, typically 5 to 7 years later than homozygotes. So what we've seen today represents a fundamental shift in how we approach Alzheimer's treatment for APOE4 carriers. For the first time, we have evidence of actual cognitive improvement, not just slower decline. With patients gaining back function they had lost, we have comprehensive brain protection across all regions, saving over 1 million neurons. We have zero risk of ARIA, making it safe for all of us, and we have a clear understanding of why targeting oligomers and not the plaques is the key to our success. This isn't just another incremental advance. I'm actually very hopeful on these treatments. It's a paradigm shift that could make Alzheimer's prevention a reality for APOE4 carriers. And for all of us who've been told we have limited options, this data offers real, tangible hope. Just a small word of caution, this is still very early. You have to know that this clinical trial actually did not meet its primary endpoint, and these are only secondary findings. So typically those are not approved by the FDA, and they will need to do more research and more clinical trials to validate that. But I believe it's extremely promising and gives us a lot of hope regarding this specific molecule. The key takeaway for this session is that early intervention with oligomer prevention, potentially starting when biomarker tests first show changes, could change everything. But you don't have to wait alone for these treatments to become available. At the Phoenix community, we're tracking development like this in real time, helping members understand their options and prepare for what's coming. If you want to get access to this drug but can't yet, I have written a blog post. You can find the link below where I discuss options that exist today. Head into the description and click on the link to access this blog post. All right, stay informed, stay proactive, and remember, we are not just carriers of a risk gene, we're carriers of possibility. Together, we can rewrite the APOE4 story.